Okay, thank you. From Namibia perspective, um, okay, sorry. Okay, in terms of our public health commodity supply chain, procurement flows from the central medical stores, and supply chain is through 4 levels of, as illustrated on the diagram there. But however, it's important to mention that everything goes through CMS to the regional depots, but still the majority of the supply chain goes, it bypasses those regional depots to the health centers. And those regional depots are the ones situated in the mostly dense populated areas. But however, the majority of the population is served by the public system of up to 85%, while the private sector only serve up to 15%. In terms of our supply chain force, the top level is the pharmacist, of course, and I don't have to re-mention the other one, but in terms of our challenges, the one that I can really highlight is that we have had a 300% increase in procurement with a little change in our staffing, and that's, as you can see, over 10 years. We also have insufficient staff across the whole supply chain. And perhaps I should also mention the last one that we also experience with maybe poor motivation and high staff turnover. And I must mention that in our public system, we only have currently 11% of the registered pharmacists in the country, while the rest are in the public, in the private sector. Thank you.
So this is we're talking about a collaboration, so we're having a collaborative presentation as well. In response to these challenges, the government of Namibia has taken a number of steps, including relocating and restructuring the supplies unit within the Ministry of Health, training medical stores staff, strengthening pre-service education in supply chain management, and also recruiting additional staff, expatriate staff from overseas to fill gaps. In addition, 2 USAID projects, SCMS and Capacity Plus, have joined forces under the People That Deliver umbrella to support the government's efforts in planning, training, and retaining staff, and also in documenting and sharing the experience and lessons learned. The collaboration involves 4 interrelated activities. First, a competency mapping exercise to identify gaps and overlaps in key supply chain functions, which draws from the PTD Competency Compendium. Second, we're applying the WHO Workload Indicators of Staffing Need methodology, also known as WISN, to estimate the types and numbers of supply chain staff needed. Third, we're implementing a performance improvement program to identify knowledge and skill gaps and design competency-based training to address those gaps. And finally, we're conducting rapid retention surveys using the discrete choice experiment methodology, known as DCE, to create incentive packages that encourage job seeking and retention in the public health supply chain sector. The competency mapping was completed in April, and other activities began in March and April and should be completed before the end of this year. And that will be followed by a meeting with local stakeholders to present the results and discuss the way forward with recommendations. And I'll hand over to Ben to discuss more of the activities.
Thank you. So what are the required competencies and skills for the supply chain workforce? To answer that question, that is why the competency mapping exercise was undertaken using the PTD Competency Compendium. And Namibia was the first country to apply this compendium. And really it went through a desk audit, reviewing a lot of documentation, standard operating procedures, assessment reports, policies of government. and a stakeholder engagement meeting, followed by focus group discussions and interviews with the staff at central medical stores and regional medical stores, and a development of this draft competency framework, which now underwent validation through those meetings. So there was the competency framework was developed across the 5 domains of selection and quantification, procurement, storage and distribution, resource management, personal and professional. And you did resource management and personal and professional yesterday, those who were there in the leadership workshop. This competency framework is being used to inform the workload indicators of staffing need assessment, which Rebecca has just mentioned, and to review job descriptions, and also to inform pre-service education programs. One of the things we found, and which is a question which has been coming up, is the issue of the culture, pharmacies being the culture of the supply chain workforce. It's a tradition which has been carried along, and it's something that takes a lot of advocacy to start to really change and see that there are other public health logisticians that can take up those roles. Okay. In terms of what types and numbers of supply chain workforce are required, we did the workload indicators of staffing need assessment, which is what Rebecca has talked about in setting activity standards, which requires an expert working group to sit together, data collection of service statistics and other transactional data, which will tell you, what kind of workload is the supply chain workforce are doing, and inputting these into the Within software to come up with the requirement calculations. This has been done at health facility level, which has indicated that 4 times more supply chain workforce in terms of pharmacists and pharmacy assistants are required at that level. And even at health centers and clinics where it's mostly nurses, you find that the workload that they face shows that more than 122 pharmacy assistants are required at that level, where there's only 8 right now. So the results for the central and regional medical stores are yet to be validated, but those are the preliminary results are ready. So it is very important we are realizing that you have an expert working group that is really engaged and well trained, so that they can support this activity, because the activity standard setting is very critical. And I've already talked about the wide scope of pharmacies in the supply chain, which we need to advocate a lot at this level and also at country level to have it shift the thinking. In the discrete choice experiment, which Rebecca has also mentioned, we were asking ourselves, how do we build in? We're asking ourselves, how do we? What kind of incentives will help recruit and retain the supply chain workforce, and what package of incentives is feasible to implement? Focus group discussions were held with the pharmacists and pharmacy assistants in the private sector and also the public sector to kind of come up with the bucket list of desired incentives, and so this will be used to develop this data. It was used actually to develop this survey tool, which has this package of incentives that people have to kind of choose and make decisions based on what they think is more desirable. The final results are yet, or rather, the tool is yet to be administered nationally, simply because there is a very lengthy institutional review board approval process, which we learned the hard way. So we are still waiting on this and should be able to roll this out before the end of the year. So one of the lessons learned also is that we should expect some resistance. This is a very sensitive issue. Salaries, salaries of health workers, especially in low and middle income countries, it's not very good. It's one of the reasons why there's a lot of migration. So it's a topic that generates has a lot of sensitivity around it, and we need to anticipate that. Last but not least, the supply chain performance improvement program. We're asking ourselves the question: how do we build individual and organization capacity, supply chain capacity for that matter? And to do this, we undertook several activities. One of them was supply chain executive management training, we realized that to implement some of these activities in country, we needed to kind of introduce the managers to this activity, get them into the picture, get them to understand it, and you know, appreciate it. There was a series of you know, meetings, a system strengthening visit to really look at what are the key issues that that the managers really want to prioritize for intervention. So from that, a self-audit was conducted, and gaps were identified. A lot of job descriptions and standard operating procedures were updated. These had not been done for almost 6 years, and you know, this was making the people ready for the interventions in terms of training of staff on the reviewed procedures. Also, key performance indicators were developed, or rather, you know, baseline measures were taken. Four key performance indicators were identified. Output indicators in terms of the number of the key documents that are in place, and the staff, you know, doing activities and functions according to these documents, and output is indicators, outcome indicators in terms of you know, on-time delivery of products to the health facility level, and the service level, or the order fulfillment rate by the medical stores, which is the key metric that everyone else is always interested in knowing. So the training component of this will be taking place later in November. And you know, it's something we realize there are always scheduling challenges. You never get to do things as planned because you're working in the real environment. So I'll leave Rebecca to finish off.
So Ben mentioned some of the lessons we've already learned. The general lessons I'm presenting here, as he mentioned, some of the activities are taking longer than expected. There's been some procurement challenges at central medical stores that required urgent attention. So our activities were less of a priority for a while. Nevertheless, PTD has provided a platform in Namibia that has facilitated coordination and collaboration across different projects and organizations. And the collaboration showed that it was possible to adopt the PTD Competency Compendium, as well as other human resource management tools and approaches to inform planning and retention of supply chain staff. And the efforts also have required strong field office leadership and global technical support to maintain the momentum. The next steps will be to finalize the 4 activities and then meet, as I mentioned before, with national supply chain stakeholders to discuss the results and agree on a recommended way forward. And we will complete the documenting of the process and results and write a case study that will be shared with the PTD community more broadly. Thank you.
Conscious that we are a little bit behind time, but also conscious you have aching questions. So if our volunteers could start moving amongst the audience, we will take a round of a quick 3 questions and then encourage you to interact with our panelists over morning tea. So raise your hand quickly if you want to be in the 3. And if our, this one down the front here was very quick. So here, and at the back. Great. Please introduce yourself briefly and your brief question or comment. We'll start here. Thank you.
Thank you very much. My name is Jean-Baptiste Kakoma. I'm the Dean of Rwanda School of Public Health. I will address my question to Burkina Faso. Since the presentation was in French, I will ask my question in French. Ainsi, vous disiez que la formation, c'était de niveau maîtrise 2. Je suppose que c'est maîtrise complémentaire. Suivant Bologne. Et par conséquent, je voudrais savoir quels sont les prérequis pour l'admission. 1. 2. Quelle est la durée de la formation? Et enfin 3. Je souhaiterais savoir si la formation est de type exclusivement académique, professionnel ou les deux à la fois.
My name is Ubedi Abu. I work with USAID in Malawi. My question goes to either Burkina Faso or Namibia. I want to learn from your experience. We are advocating of creating a cadre that will fill in the gaps in supply chain management outside clinicians or pharmacists. My question is, do we have this cadre available in the market to be recruited? Because as we are creating this shift, we are also creating demand. Are those cadres already existing in the market for them to be employed into the system?
Thank you. Hi, I'm Jennifer Rubin. I'm with UNICEF Supply Division. I have a question, and it's actually, I think both countries can address it in terms of their activities. Just curious to know the extent to which there are structural or regulatory barriers to the activities that you're implementing in terms of incentivization policies around recruitment and how those have been or can be addressed. And also in terms of the extent to which this has been something that's been incorporated, for example, into a national health plan that can be budgeted, et cetera, and if there are any challenges around that. Thank you.
Jessica, you can go first.
Ok, merci. Pour la première question sur la durée, sur la formation du master, donc c'est un master 2, donc qui dure 2 ans, maîtrise et master, qui est sur le système LMD, qui est basé sur le système LMD. Donc les candidats à l'entrée du master, donc les prérequis, c'est un niveau licence minimum, donc 3 ans d'études pour les inscriptions externes. Pour les inscriptions internes, ce que j'appelle interne, c'est sur concours de la fonction publique. Les candidats doivent être préparateurs d'état en pharmacie, avoir une expérience professionnelle au sein de l'administration de plusieurs années et d'avoir également un niveau licence. Voilà. Après, la formation est à la fois académique et professionnelle. Les étudiants alternent entre cours théoriques et pratiques, avec des stages professionnels au sein de structures de santé et des applications terrain qui sont organisées par l'Institut Bioforce. Voilà.
I'll try and address the question on cadres to fill the gap in supply chain management. Are these cadres available? I think the question is yes and a bit of no. In the medical store, for example, in Namibia, there are pharmacists, there are pharmacy assistants, and there are clerks. One of the things that we've realized that the job of a clerk, actually the official title is administrative officer. And this sounds like someone who works in the office, doing some paperwork, not a logistics, job. So when a job is advertised, somehow it doesn't click on some of these people. The Polytechnic of Namibia, which is one of the local institutions, is training a Bachelor of Logistics program and also at a master's level. So yes, there is opportunity to get these people in, but the structure, the current structure of the government of Namibia does not have specific job descriptions for logisticians, and it's something that we are trying to work on in terms of advocacy. And to address. And it's simple things like just changing the job title when you're advertising and call someone by the job that they actually do. Okay. On the issue of structural and regulatory barriers, they are not specific ones, but it's always tied to what is the national government incentive structure and job grading structure. Because you'll find that they will say, a job grade such and such is what works at this level. And to attract people to certain positions, you need it at a higher level, but that is the level that is provided for in the central medical store, or in the regional medical store, or at facility level. So there's you can say there's a bit of a barrier, but there's a whole restructuring going on, which presents an opportunity to try and put people at a higher grade where you can attract the more professionally qualified logisticians. Thank you.
Thank you. And I think from a people-led delivery's perspective, you'll note that we're trying to work on a goal of demand, asking governments to demand, but also supply. So working in local environments to look at its supply. So we recognise that balance is needed. Thank you so much. And please join with me in thanking our presenters.